I wanted to say welcome everybody for joining us this evening or afternoon. We're here to talk a little bit about earlier surgical intervention in the management of your mild to moderate glaucoma patients. I'm Dr. Leslie Odell from Medical Optometry America, and a little known fact about me is I did my residency training a while ago now at the Baltimore VA hospital, and although I speak a lot on dry eye, glaucoma is kind of my roots, and I'm always excited and honored to have an opportunity to share the stage with somebody like Dr. Lighthizer and speak about glaucoma. So thanks for being here as well, Dr. Lighthizer.
Oh, it's my pleasure to be here, Leslie. It's all my pleasure to share the virtual stage with you on our little glaucoma talk on OMNI, and really talking about glaucoma intervention, surgical intervention in those mild to moderate patients, which we'll get into in just a little bit. A little bit about me. I'm a faculty member, associate professor at the Oklahoma College of Optometry in Tahlequah, Oklahoma. I serve in a variety of roles there, including the chief of our specialty care clinics and the director of our continuing education program. So my pleasure to be here, and I'm looking forward to chatting with all of you guys on surgical glaucoma.
I think it's a really important thing to talk about interventional glaucoma and really just, the options we have to treat our patients, because you can see the landscape of glaucoma moving forward, and we just see increasing numbers of patients that are going to be affected by the disease. It's almost, double where we were in 2010 with the numbers projected for 2050. So just glaucoma on the rise for many reasons. So we're going to be seeing a lot in our clinics, and it's good to have opportunities, not just with traditional ways of treating the disease with medications, but really to be thinking of interventional glaucoma and really turning the attention to that mild to moderate patient, and how can you maybe be a little bit more aggressive in treatment earlier on in the disease process to help the journey, the lifetime of your glaucoma patient, preserving vision being number one, and really also quality of life that comes along with a lot of what we ask of patients when they're using topical medications from day to day. So what that really means is where we've gone surgically. So when I started my training, it's actually kind of a little bit even past where this bar graph begins, 2003 and 4. I worked closely with the glaucoma surgeon at the time, and the only option for my patients surgically was ALT and trabeculectomy. And thankfully, he was a very skilled surgeon. And so I did feel confident about sending my patients for trabs at the time. And then we've seen the evolution of things, like tubes come into play. But what's really been exciting is this minimally invasive glaucoma surgery, and the way that this has expanded over, really the past several years, and where we predict it to go in the future. So minimally invasive procedures involve things that can be done sometimes in combination with cataract surgery, and now even standalone without that. And you can see how it's expected to really continue to increase as time goes on with our population of glaucoma patients.
Yeah, Leslie, just going to add in there, we all know our patients are aging, the boomers getting into their 60s and even 70s now. And we are just seeing an abundance of cataracts, abundance of macular degeneration, glaucoma, dry eye, diabetes, and diabetic retinopathy. So we certainly are going to see a ton more of this going forward. The data shows that. And I just wanted to echo and second what you said is I think we battle compliance, and we see progression, and we have to kind of scratch our head of going, why is this progressing? We know it's a progressive disease, but is it progressing because it's indeed a progressive disease? Is the patient not taking their drops, or the drops not working for them? So this concept of interventional glaucoma, as you said, of looking to procedures a little bit earlier in the disease process, I think is beneficial in numerous aspects, most importantly, patient care. So I think it's going to be important. I think that's why you're seeing the data over the course of the next decade or so. Really, this is, I guess, the next 4 years, that this is going to go up and up and up. This whole graph shows a decade or so, but it's just going to go up and up and up in terms of MIGS procedures due to the safety profile and the efficacy profile as well. We forgot to mention, encourage all attendees to put their questions in the chat. and share them in the chat, and they will be addressed along the way or during the Q&A at the end. So you have any questions along the way, please put them in the chat. We will address them either during the presentation or at the end during the Q&A as well. So Leslie, I'm going to kick it back to you.
Well, you know, what you're talking about too is just that this population of patients, well, first of all, I guess your early conversations with your patient about we don't have a cure. No matter, you know, what we do, we can slow progression, but we can't stop progression, and really setting the expectations for patients so that as their journey continues, they're not kind of caught off guard or think, well, we didn't really talk about a second drop or a procedure. Actually, I just had a patient that I was talking to about some MIGS, and I was talking first about SLT with this woman in particular, and she, which, you know, maybe wouldn't fall necessarily in this category, but she immediately put her arms up like, no way I'm ever doing laser on my eye. And then the more I got to talking with her, I realized that she had taken her father-in-law to a retina specialist, and he was getting retinal laser and actually anti-VEGF injections. So the whole thing just kind of scared her. And that's where I think actually taking it back a step and figuring out maybe what might be your patient's hesitation when you're talking about any kind of minimally invasive surgery, and then really with the experience that you've had with your other patients, knowing your surgeons that you're referring out to, kind of ensuring them that you're trying to actually enhance their outcomes, right? Preserve their vision, and gain their trust so that they, you know, consider these things. What I also find is that a lot of times MIGS and procedures are not even discussed, you know, with a lot of their providers. I've recently taken over care for a retiring provider who, you know, was really 1 med, 2 med, switch med, never once even talking about other procedures. So I feel like I've been playing a big part in just educating patients to all that's happened in the past, you know, decade or so in that glaucoma interventional landscape. That being said, kind of when you think about MIGS, you don't want to think historically about what maybe one of the first MIGS that we started working with was, which was a stent. This has really now run the gamut, and now we're seeing that minimally invasive glaucoma surgeries are done independent of cataract surgery. So that's considered a standalone procedure. So we're not limited anymore. And you'll see in some later slides that that's great because it opens the landscape of patients that can be treated with these type of procedures to just treating during the time of cataract surgery. They can be performed as a solo procedure, which is amazing and exciting, you know, for so many of our patients. And also, you don't have to wait until the end. This is where working with some of my glaucoma surgeons always is frustrating, because I see these, you know, 9099 cups now finally getting into the hands of a glaucoma surgeon when, you know, we could be doing a lot better job of getting them earlier in the disease process if we just kind of stay educated and learn what all of the treatments are available to patients that are outside of the bottle. And why MIGS, you kind of touched on this earlier, but it's safe. You know, these have proven safety profiles. They're effective at lowering IOP, sometimes reducing the medication burden. You know, I do give my patient hope that I can do that, but I don't promise them that we're going to be dropless after any of these procedures. But I do think just talking about the reduction of medicine burden, which could be side effects of medications. We now live in a world where we're recognizing that chronic use of BAK preserved medications can be harmful to the ocular surface, can be harmful to the meibomian glands. You know, I also remember in my training when the cornea was just like the window into the nerve, and it was okay if there was 3+ keratitis, it really didn't mean anything. So I'm happy to see that we're trying to preserve corneal health while we're preserving optic nerve function and health. And also, you know, that becomes a reason why people maybe fall out of adherence. You know, it's not uncommon for you to have a patient that comes in and say, my eyes didn't bother me till I started using that eye drop that you told me to start, you know, or, oh, I stopped that drop because it was burning me so badly. So, you know, we have to be thinking about that. And then kind of what you were touching on earlier about our patients are growing older, thankfully, with us. It's a burden. You know, sometimes I like to watch the patients to see, arthritis in their hands sometimes makes it a challenge to put their drops in. We've all seen the horrific videos of missed drops or poking and, really rubbing and scraping around the eye. So the burden that you not only put on the patient to make sure they're adherent to medication, but if they have family that's taking care of them, a spouse that's taking care of them, now we're, asking a lot when we're saying, multiple meds, multiple times a day.
Yeah, Leslie, just to add to that, I think that initial conversation with a glaucoma patient is so critical to spend some time. And maybe it's not that day. Maybe you're just incredibly busy that day and, it needs to be brought back in a week or 2 or 3 or a month or whatever it is. But having that initial conversation with the patient that, this is the reason we diagnosed you with glaucoma. You show them the pictures, the OCT, the visual, whatever it is, a picture is worth 1,000 words. And having that conversation that you and I are in this together. This is our ultimate goal is to keep you from vision loss, which we usually do. We usually can keep you there. Glaucoma is a progressive disease. So I can't give you a drop. I can't do a procedure on you to fix this, to cure this. We're going to manage this together. And we've got a variety of options. We've got drops. We've got this laser or light therapy, SLT, and we've got these great surgeries. Some are more invasive. Some are less invasive. Some carry a better safety profile. Some carry still a good safety profile, but there's a little bit more risk. And I'm going to be forthright with you at every step of the way of this is what I would recommend at this point. This is why we're doing it. But if you introduce drops and laser, SLT, and MIGS and surgery and say, okay, these are all the possible options, and this is the order we're usually going to go in, and I'm going to keep you updated at every step of the way. I think patients remember that, and you've gained a patient for life by going through and just explaining it so they can understand it at their level.
And I think that I have long since used all of these kind of foundational research. I guess I don't know what the right word is right now, but so I used the like AGIS and the NTG study to really help me figure out my target goal and really lay out the path. So I think really also just getting to the basics and knowing what your Tmax is, what your patient's goal is so very important when you're talking about that journey, right? If you don't have a end game, you don't know where you're going. And then when something doesn't look right, when you see the patient back, you kind of feel like, well, now I don't know what to do. So AGIS, I lean heavily on. We know from AGIS that if you keep the pressure consistently low at 18 or less in an advanced glaucoma patient, we're going to see limited progression over time with visual field testing remaining stable, over a 6-year span of these patients being followed with no progression. And also that every point matters. So the other big takeaway from AGIS was every millimeter of mercury lowering, we preserved, progression. We reduced that risk for progression by about 10%. So, I think that's really important to kind of remember that for patients too, is that you want to think about every point mattering. And then I also look at AGIS for not only this 18, but, in my really advanced patients, sometimes I'm lowering my threshold into the low teens, 14, 12. And then, there are patients that maybe start out low tension that this doesn't apply to, but that's where you kind of look to, NTG study and other studies along those lines. But I think you need to kind of have some kind of foundation, and even just starting treatment, with one eye pressure can sometimes be a challenge because you don't see the variation in pressure. So I actually would ask you how you do that with an initial patient, depending on nerve status, vision status for your very first encounter with the patient. Are you bringing them back at least, in a short amount of time to see about what another pressure looks like before you're initiating therapy?
Yeah, it's a great question, Leslie. Obviously, it depends on the case. If you have a patient that walks in with a 0.95 cup and a pressure of 42 that hasn't seen an eye care provider in years or decades, we're going to initiate therapy that day. But that's not most patients. Most of our glaucoma patients are POAG patients when they come in. And I want to have at least 2. And a lot of times I'm going to want 3 separate pressures. We do have time. in glaucoma a lot of the time, not all of the time, but a lot of the time. So I'm going to want at least 2, maybe 3 pressures, occasionally 4, to get multiple readings, different times of the day if possible, so I can see where their pressure is at. You have time, and I'm not going to separate them out by 6 months where I'm going to see you in 6 months. I'm going to, okay, I'll see you in a few weeks or a week or, 3 weeks or whatever it is. And 2 to 4 pressure readings so I can get a good idea. This is where their pressure is running. Ideally, that's what I'm going to do in the vast majority of patients, to get multiple pressure readings before we pull the trigger on treatment.
I think that's important. I mean, and even when you do that, you might get that, say you're shooting for an 18 or less, and then you have a patient on therapy and they come back at a 24, and then you think, okay, well, my Tmax might not have even been, above that before. So every once in a while you might get kind of the curveball, but I think setting your goal is important. And too often I see that we kind of don't do that. And I kind of do parallels between the 2 main things that I'm treating with dry eye and glaucoma. And I, do the same thing with my dry eye patients. I have a treatment end, and I have the same thing with my glaucoma patients. I have a goal in mind. I watch for change over time, and then I actually can change my goal if things aren't going as planned.
I think a target pressure is so important, Leslie, and it's not set in stone. We can have a target pressure base. Remember the categories of mild versus moderate versus severe glaucoma, often referenced based on a visual field criteria. What stage of glaucoma does your patient have? Okay, based on that, based on their age, based on other factors, this is my target. I typically will have a range or say, I'd like it less than 18, or I'd like it 16 to 18. If you have a patient that's got severe glaucoma, I want their pressure at 10 to 12, based on the studies. So setting that target pressure is very important, and keeping that pressure less than 18 millimeters of mercury based on the AGES study, very important to limit progression.
So this is what I was touching on earlier, just the journey of our patient. It's easy to see a patient one day, then again in 6 months or 4 months or whatever it is, but really to kind of think about their journey, I think helps you make better decisions for that particular patient. So in this case, we have a 73-year-old patient, newly diagnosed, mild to moderate visual field defects. So, on your, discussion about visual field, I would assume this is -6 on the mean deviation, elevated pressure, early thinning on RNFL. This is a nice patient to have because they make your job easy. At least you have a clear-cut diagnosis of glaucoma, right? This patient, you want to initiate therapy. It's still, a lot of times first-line therapy to be reaching for a PGA. It's a monotherapy once a day. We know compliance is an issue, so the least amount of medications we can use with the least amount of frequency, for the better. But then you're going to see your patient back. And say you see this patient back, you've seen them back for their initial eye pressure check, everything looks good. You see them back again in 6 or 8 months, and now you're above this target pressure that we say is so important to have. And you've also maybe seen some progression. Well, now you're at this crossroads that you could do a second medication. We know we have lots of good adjunct therapies with topical therapies. And so you go with the second med. You keep continuing on the journey of seeing the patient at your scheduled intervals for the testing that you're alternating between, optic nerve structure and function testing. And then you see again some kind of progression, either they're above target pressure or you see something that you don't like on your OCT or your visual field. And now you're at another crossroads. So your options now, again, are initiating another medication, maybe switching to some kind of combo therapy. And then, this is kind of the traditional way. 1, 2, 3 meds, and then we're passing on to surgery. And so what I think that where I think we are right now with all of the science we have and all of the options that we have for patients, if you just click one ahead on this slide, we really see where MIGS kind of falls into play for this patient. And really, you can start in the mild to moderate patient. And I think you said this beautifully when we were doing a little pre-work, Nate, and I'll let you say it again, but really when you get to that first crossroads of adjunct therapy, it's a great place to talk about MIGS to your patient. And maybe you can just restate what you had said to me a few days ago.
Yeah, I mean, I really think that, we have a paradigm shift over what we've been doing the last 2 decades, 3 decades, 4 decades, where it's drop number one, drop number two, drop number three, drop number four, and patients are battling compliance and adverse events and things like that. I as a clinician, I sit down and think to myself, when I am about ready to add the second drop, and I'm a big fan of SLT, as Dr. Singh and I will talk about tomorrow. So if I go to SLT first line, I'll consider adding a drop. When they're adding a drop, well, for the second drop, they're already on one drop. And now I'm making a decision. I need to add therapy, and adding that therapy will now require a second drop. For my patients in Oklahoma, when we add that second drop, I see compliance tank. Compliance is difficult enough with one drop, let alone now we're adding a second drop. So to me, I encourage everybody to think about, okay, when we're adding that second treatment, usually a second drop, that's when I really would consider we need some sort of procedure. Is it SLT or MIGS in this particular case? We need to evaluate that. So I think that should be thought of in a lot of patients, or even they're on one drop, but yet they're struggling with it. Maybe it's the compliance, maybe it's redness. If you're struggling with one or about to add the second, I think that's when we really need to change that mindset and going, okay, let's help this patient out. Let's help me out as the doctor as well, and get them on a reliable treatment that I don't have to worry about compliance, some sort of surgical procedure like a MIGS. So I got one question here. Do you have patients come in for a diurnal curve very often? Leslie, I'm going to get your thoughts in just a second. I'll provide my answer here. This is not something that I do often. Have I done it before? Yes, but I don't often have them come in for a diurnal curve. I will try to get kind of a semi-diurnal curve by having them in at different times of the day. We have them in the morning, we have them in the afternoon, early afternoon, late afternoon, etc. So I don't often do that diurnal curve, and just try to get different pressures throughout the day. Now, if I have a patient that is progressing despite stable IOP, stable IOP, stable IOP, stable IOP, and going, man, this pressure is right where I need it to be on target, yet the visual field, the OCT, the nerves are showing signs of progression. That's where I would consider maybe a diurnal curve, or one of the at-home tonometry measurements that we have, like the eye care home or home 2. So that's where I would consider that. Leslie, what's your thoughts?
Well, I have done different times of day for patients, but in theory, we're not really catching their highest read unless I'm coming in at 4 or 5 a.m., which I'm not doing, thankfully.
Yep.
But one thing that I have been using in the past year and a half is something called the Falk multifunctional tonometry or tonometer. So it attaches to my slit lamp, and it's been really interesting. It gives me serial tonometry. So I get about anywhere between 70 to 90 reads on a patient. And it goes through 3 cardiac rhythms and gives me the average of about 70 to 90 IOP reads. And I will say that if I compare that to my gonio that day, it is usually not the same number. So say my Goldman, I'm sorry, I say gonio, but my Goldman, say my Goldman is 18. Sometimes my serial tonometry might be 22 that day. It's almost kind of like the your CH and your IOP-CC versus your IOP-G, and how they can be a little bit variable too. So I've really been kind of learning about that as an option for these patients. And I've been doing a lot of serial tonometry for patients. The other really interesting thing about this Falk multifunctional applanation tonometer is it measures outflow, which it looks like your Goldman, and it kind of acts like your gonio lens, which is probably why I said gonio. So it's like a prism that lays on the cornea, and it looks like when you get that nice section of your gonio lens onto the cornea. So it gives me a number for outflow, which obviously plays a big role when I'm kind of considering things like MIGS or SLT. And then it also helps me with my ocular perfusion pressure. So, something to definitely look into as we learn more about that. But it's been a good tool for me and helps me with this sort of diurnal or like serial reads, trying to gather more data before I pull the trigger on treatment.
Yep. Yeah. So take home point on this one. Let's is just, you get to that, you don't battle that second drop and third drop as much as we have to. Thinking of surgical intervention earlier can be very beneficial for our patients.
Well, and this is what I just really, we touched on it a little bit, but I think this chart is really very good and very visual. So notoriously, we have thought about MIGS procedures during cataract surgery, right? Because that's how we had to do them. That was when they were going to be covered for the patient. But if you look at this pie chart, you see that that's only 15% of your patients that are living with glaucoma. So by doing what's considered standalone, so something independent of cataract surgery, we now can gain this 85% of our patients with POAG that weren't maybe falling into what we were traditionally considering a combined MIGS surgery. So I think this standalone category really opens the door to allowing more of our patients, into the treatment bucket. And I think if you just advance to the next slide, we can kind of just quickly touch on who does that mean. So, okay, now we're saying you can do this to patients that are not going into cataract surgery. At the beginning of this, we used to say this is a once in a lifetime opportunity, not only for you to figure out how you want to see for the rest of your life, but how we want to get you some independence from glaucoma meds. Fortunately, now that's a different conversation, right? We can now say, you don't have to just make this decision at the time of your cataract surgery. We can do it before, we can do it after. So the candidate is, all the people we've already talked about, patients that we just need lower eye pressure on, patients that you said might be on one med, but are hitting a wall for whatever reason, cost, side effects of just even one medication. Adverse events from therapies, you definitely run into patients that have a long list of allergies maybe before you've met them, or you do start them on therapies and you quickly see that they're not tolerating them very well. And really some patients, just when you give them the option and they have an option to take it out of their own hands, they're willing and able to explore that because they know they're not maybe as reliable with medications.
I think it's important, Leslie, on these are all ors. They're not and. It's not and where these are all together, right? And you have to have all these. Any one of these can be an indication to consider a MIGS procedure. Again, as we've covered already significantly, any one of these. And let's consider and go, what would be the best thing for this patient to reduce the burden and help prevent progression? And again, for me, it goes back to that. All right, we've got them on one eye drop, one glaucoma drop. I really need to make a decision on which road is best for this patient at this point. Is it a second drop? Maybe it is. Is it a laser procedure? Maybe it is. But we also need to consider that third road of, would a MIGS procedure be beneficial? And oftentimes, boy, it really would be, to help reduce the pressure and reduce the number of medications they're on, which we'll get into in just a second.
On that list, real quick, I would say, this one that said progression despite maximum medical therapy, I hope we start getting away from that, because that was exactly when we were, when doctors were notoriously sending for TRAB. So I think that because of the safety and the efficacy, we can sort of push the needle down, which is what I hope to see in the coming years.
So the evolution of MIGS procedures, this leads us into the OMNI Surgical System by Sight Sciences, and it really is a phenomenal device. And I know we have both optometry and ophthalmology on this call. Obviously, Leslie and I are optometrists, so our ophthalmology colleagues are much more familiar with us in terms of the actual device inserting it into the eye. But you can take a look at the OMNI Surgical System, a nice handheld device. You can see on the end there the cannula that you can have the microcatheter come out of that viscoelastic fluid. We've got the fitting, the lure lock, the priming lock, the gears that facilitate smooth microcatheter deployment and then retraction. It's important to remember that this is implant free. There is nothing that is left in the eye in terms of an implant after the procedure, but this is the handheld device, just so you guys could see it. The handheld device here that's inserting the catheter, viscoelastic going through that, as we'll talk about in just a second, and then retracting that as well. So that is the OMNI Surgical System that I'm sure many of our ophthalmology colleagues have utilized there. So how does this work? It's important to remember that there's multiple points of resistance on the traditional pathway, the trabecular meshwork pathway. And we have a lot of medications that work in different ways. Our prostaglandins enhance uveal scleral outflow. Beta blockers decrease aqueous production. CAIs decrease aqueous production. We didn't have a whole lot that did med-wise that increased trabecular meshwork outflow. But remember that the resistance at that level can happen at the TM. It can happen at Schlemm's canal. It can happen at the collector channel. So only addressing one of those, if you get it through the TM and going, okay, we've overcome that point of resistance, you can still have Schlemm's canal that's collapsed or atrophied away. The collector channels can have the same thing where they've collapsed in on themselves. They're blocked. And we've got resistance at points that are distal to the trabecular meshwork. OMNI does a really nice job of addressing all 3 points of resistance at the trabecular meshwork, as we'll talk about in just a second, at Schlemm's canal, and at the collector channels, which we'll show you here on the next slide. So it combines 2 distinct implant-free procedures, the canaloplasty. So the device is inserted into the eye, that microcatheter is inserted into Schlemm's canal, and it's retracted, and it viscodilates Schlemm's canal and the collector channels. That's the canaloplasty to help remove resistance there. Then the device can be removed through the trabecular meshwork for your trabeculotomy, basically unroofing the TM, and we've now helped to remove a point of resistance there. So it's a standalone procedure. A solo procedure is another way of saying that, meaning they don't have to be at the time of cataract surgery. They could be before cataract surgery. They could be after cataract surgery in a pseudophakic patient. But the beauty is here is to have multiple points where we can provide relief to resistance, which makes it very nice for these patients. So again, you see the mechanism. I'm going to show this one more time because I think it's important to show this video here. As you can see on the left, there's the canaloplasty. 180 degrees is done right now. Okay, and we're injecting, or the surgeon would be injecting viscoelastic to viscodilate Schlemm's canal and the collector channels, as you can see here. And then obviously, if you were treating 360 degrees, it'd be inserted in the other direction. And then there's our trabeculotomy to unroof the TM. Again, implant-free, either with cataract surgery or standalone. So I think we've covered this already. We've hit this a lot. The indications for use is for a canaloplasty, which is microcatheterization and transluminal viscodilation of Schlemm's canal and the collector channels, followed by a trabeculotomy, which is a cutting of the trabecular meshwork to reduce intraocular pressure in adult patients with primary open-angle glaucoma. Notice it does not say at the time of cataract surgery. So it's either in combination with cataract surgery or it's standalone. And we talked about, again, based on the clinical data, is it mild to moderate? Yes. Moderate to severe? Could be. Would you want your loved one to have very safe, very efficacious options reserved until they hit the severe stage? I think most of us would say no, would we not? I want my loved ones to have a safe procedure, an efficacious procedure that can reduce their burden done earlier. And let's not wait till that severe stage. So mild to moderate, 360 degrees, helping to relieve resistance at the TM, Schlemm's canal, and collector's channels. Again, as we talk about there, it does a nice option. But you got to have the data. And the Romeo studies, it really showed with the data in pseudophakic patients and phakic patients, what is the data? And you'll notice here, we've got 2 cohorts. We split them up again. These were all pseudophakic, standalone solo procedures. So not at the time of cataract surgery. Cataract surgery is not being done. And we've got pressures greater than 18 is cohort 1, and pressures less than 18 is, or the less than equal to 18 is cohort 2. And notice the baseline IOPs, again, greater than 18 on average, they're about 22, less than 18 on average, about 15 and a half. And you'll notice the post-op pressures, the IOP reduction. To me, the most important boxes are these 2 right here. How much did this reduce the pressure? As you all know, the pressure is going to be lowered probably more when it was higher to start with. So your pressures that were greater than 18, right at 28%, let's call it 30% pressure reduction. The lower pressures only got about 10%, but notice along with that 30% pressure reduction in the high pressures, a concurrent 30% medication reduction as well. And that held whether it was a high pressure or whether it was the low pressure cohort less than 18. So again, approximately 30 to 33% medication reduction. I think that is significant. About 30 to 40% of patients are on zero meds. If you can get your patients that are on one med or two meds down to one med or zero med, I think that's going to be a win. Again, this was the pseudophakic standalone patients, and just showing it a different way here. The medication reduction on the right, the IOP reduction on the left. In group number one, got a nice reduction in pressure, 28%, and a nice reduction in medications by about 30% as well. Group two, the cohort, the second cohort, the pressures were less than 18. Notice the 15.5 down to about 14, but as Leslie said, every millimeter of mercury matters. That is important, but we're also reducing their medication burden as well with that. So Leslie, I'm going to kick it to you. Any thoughts, comments on the Romeo data here from these studies?
Well, I like this percent on, I do like this percent zero meds, 1 in 3 patients that you can say are on zero meds and stable. That is really impressive data to me. But I think just what you were saying, anything that I can make an impact like this, reducing the pressure by this amount is going to resonate for what I'm trying to achieve with stability of disease. So this is really impressive data. And exciting to see just that 1 in 3 could be off medication altogether.
And again, if it was my loved one, if somebody would tell me we can have your loved one in a very efficacious, very safe procedure, have about a 30% drop in their eye pressure, which we know is the only modifiable risk factor, the main modifiable risk factor, and a 30% reduction in their meds. If you told your glaucoma patients, would you take a 30% reduction in your glaucoma medications? I'm guessing all of them would say yes on that. So, and it's interesting, the growing base of peer-reviewed evidence. There's more and more evidence and literature on canaloplasty and trabeculotomy used in these patients, both at the time of cataract surgery, but as well as those standalone solo procedures, either before cataract surgery or oftentimes after cataract surgery as well. So lots of literature, 2 slides full of literature and studies here talking about outcomes in these patients here. So again,
which is really good to see, because actually, just real quick, if you go back to the first one of these and you just look at the timestamps on this, a lot is happening quickly. So, the first paper here this is all in the past 2 years. Like that's, really exciting just to see the acceleration. And it's amazing to see where we'll be in another 5 or 10 years, right? This is just going to continue to grow. So always exciting to see new research in the field of glaucoma for sure.
Yep.
Used to seeing those studies from the 70s. So this is very exciting.
Correct. Lots of 2021 and 2022 studies there. So again, just reiterating before we get to some patient selections here and patient scenarios, we covered this already. I think this is really a review, the disease type. Let's try to shift that mindset of we're not saving surgery for severe. Let's not save surgery for severe. Let's think earlier. Maybe it's moderate, maybe it's mild, to reduce the burden on that patient. Lens status, it can be at any point, phakic, pseudophakic. Again, if they're experiencing medication issues, cost issues, they're not compliant, the burden that we've talked about. Obviously, they can't have severe narrow angle glaucoma. If you can't get into the angle, many MIGS procedures would be contraindicated. So you've got to confirm that with gonioscopy. But these patient selection considerations, I think we've hit these. Leslie, anything last to add on those?
I don't think so.
So again, that great starting point, that pseudophakic patient that's on one med, that's on 2 meds. And again, a lot of times, what are we making treatment decisions when we're about to add the next treatment option? So if they're on 1, go into 2, really think about what would be best for that patient. They're on 2, about to go to 3. Man, that could be tough on the ocular surface and compliance. When you're adding that second or third therapy, it's time to consider maybe another option. Is it laser? Is it a MIGS procedure? Or if they're struggling with the first one or the second one as well. So Leslie, I'm going to take it back to you for some patient scenarios.
And I will say, maybe even ahead of that, there is one question I see over here, Nate, that maybe we should talk about gold standard IOP measurement, still Goldman. I'd be anxious to hear what you're teaching your students, just because you're in an academic setting. Is that still your gold standard for IOP measurement? There's a lot that's come into play. The biggest one I would say would be corneal hysteresis and the measurements that we see with that.
Yeah, I think they said they addressed it in the chat box, but I would say very quickly that Goldman, it remains probably the gold standard for tonometry at this point. There are other devices out there that compare fairly well, but if you were going to court and were challenged on what standard of care is, I would want Goldman in my glaucoma patients.
Yeah. All right. Well, so let's look at William. He is prior to cataract surgery, a 72-year-old patient of yours with an eye pressure presenting 25, 21 on 2 meds and uncontrolled. I actually am a little confused on our own case because it says prior to cataract surgery, but then it says pseudophakic. So I'm going to just go with he has yet to have cataracts removed. So this patient would be, or maybe this was his pressure before surgery and then he had surgery and he, maintained an elevated eye pressure. We could look at it either way, but basically he's uncontrolled on 2 medications. So like you were saying earlier, maybe we could have had this conversation when we went to add our second drop, but now if I'm looking to lower his target or looking to lower his eye pressure and I am getting this with 2 meds, I'm naturally thinking about some kind of combination med or a third med, or, this is a great opportunity to be considering MIGS procedures for sure.
Yep, absolutely. And I think it means he's pseudophakic because he's had prior cataract surgery.
Oh, I was thinking prior to. So sorry, I just added a word. So now it makes more sense. So yes, that's what I was thinking. Yep. So he's already had his cataract surgery, which makes more sense to what we're trying to say. This patient, maybe we would not put in the bucket of certain MIGS, but we can put in the bucket of things like OMNI because now we have this standalone procedure. So we're not, at a loss for being able to recommend MIGS for someone like him.
I mean, you think about it, just take this patient. If you could give him a 30% drop in IOP and a 30% reduction in meds, that is a win, a big win for this patient.
So Patricia is also a patient that's struggling, uncontrolled on her medication. She's also on 2 meds and uncontrolled at 23 and 26 millimeters of mercury, and a little bit younger than the other patients. So I know sometimes doctors will think about the age of the patient and maybe kind of project out life expectancy, but even my patients that have good quality of life in their 80s, I'm still aggressive on lowering their pressure and trying to preserve vision for as long as I can. This patient is actually phakic at 57 and, not a candidate for cataract surgery. But what would you say about someone like Patricia?
Yeah, I mean, it's a very similar story. Just it's on the flip side of cataract surgery. It's before instead of after. We're uncontrolled on 2 drops. The pressure is up. And instead of adding that third drop, which again, I think we may struggle with, I think change the mentality of going, okay, what can we consider that's safe, efficacious, that's going to drop the pressure about 30% with medication reduction as well. I think that's going to be a good call in this one.
And then this is Donna. She has had prior cataract surgery and also eye stent. And she's 64 and now her pressures without meds are 29 and 27. So she is after surgery and after an eye stent MIGS. And so obviously there's room to improve here. You might consider adding a topical therapy since she's, in this range of 29 and 27 as you're exploring the option of other procedures. But I would have to guess that the reason that Donna's in this situation to begin with is something about her history. Either she was non-compliant, she didn't like medications, something got her to initially start down the journey of MIGS. And so offering something like OMNI to someone like Donna, I think would be welcomed. But in this case, I probably would initiate therapy while I was making the decision with her as to, who was I going to be sending her out for MIGS evaluation.
And I think this one is to remember, okay, we can have multiple points of resistance. It might not just be at the level of the trabecular meshwork. It might be in Schlemm's canal, and it might be the collector channels. So there may be work that needs to be done at more than just the level of the TM, even though we've got a TM bypass stent. In this case, we may have resistance distal to that and may need help with that. So certainly patient communication, providing them all the treatment options. Like I said earlier, and we said earlier, we've got this and we've got meds and we've got laser and we've got MIGS and reassurance about the safety profile. These are minimally invasive glaucoma surgeries, hence the name of MIGS, and telling them these are efficacious, that's been proven in all of these studies, but also, and just as important, they're safe to provide for these patients. That this isn't the surgery that your great grandma had, back in the 70s or the 80s. And these are minimally invasive procedures that carry a very nice safety profile. Educate on the expectations. Yes, you're, for a couple of days, a week after the procedure, maybe a little bit cloudy. If they've already had cataract surgery, they may understand that to some degree, as we're going to an OMNI procedure a couple of years after cataract surgery. You remember that, how your vision was a little cloudy for a few days? It may be that as well, but that tends to clear very quickly. This is not a cure. Remember, we've had this conversation before, and I tell patients this often of, we are going to manage this. We're going to, you and I together, whether it's drops, whether it's laser, whether it's minimally invasive procedures. We hope we don't get to the invasive procedures. That's our goal. We're going to work together. But remember, I'm going to need to see you 2 times a year, 3 times a year, 4 times a year, depending on the severity with that patient there. So again, there's the indications, the contraindications. We've really covered this with the product information already. So with that, in our last 5 minutes, we've been monitoring the questions throughout. If there are any questions, please type them in. We go, how do you find a provider in your area that does OMNI? It's a really good question. I would encourage you to connect with your local site sciences rep, who's going to certainly know the local surgeons in your area that do this. Obviously, you can develop relationship with your fine ophthalmologist in your area. Who does this? Who doesn't do that? Looking on the Site Sciences website, they have tremendous resources there. But talk to them in the virtual exhibit booth, visit the virtual booth here at the meeting, and they certainly would be happy to chat with you and connect you with your surgeon there. Any other questions? Let's see what we got here.
I'm always excited to learn new technologies like this. And that's exactly how I found the surgeons in my area, was leaning on site. So I definitely would say, now that you've learned a little bit about OMNI, the best thing to do would be jumping over to that virtual booth, because they can connect you. And actually, I met some great surgeons in my area just because of this technology, that now I have, another resource for patients in my area, which is always a good thing.
So key final points here as we're waiting for any last final questions. I'm not seeing any in the chat box. Again, the takeaway is, think of that interventional glaucoma and the days where we have patients battling 3 and 4 medications, I think have gone by the wayside. Again, SLT used to be after 2 and 3 meds, and now it's really considered first-line therapy. And MIGS is a glaucoma surgery that is not reserved for only the severe patients. It's the mild to moderate patients. And MIGS are not just with cataract surgery. They can be solo or standalone procedures. That patient that is struggling with drops or is progressing and you don't think the next drop would be ideal for them, really imperative to consider an OMNI procedure, a MIGS procedure like we've talked about, and looking at those 3 points of resistance to be able to help to relieve with the trabeculotomy, the TM resistance, and the canaloplasty to help relieve the Schlemm's canal and the collector channels. I think it gives us an ideal option for a lot of patients when we're talking about surgical therapy that's safe and efficacious. Any last thoughts, Dr. Odell?
I think just what you said there, wrapping up, is safe and efficacious. I think, again, patients look at surgery and they become very leery of eye surgery in particular. So just having the conversation, explaining what minimally invasive means, and giving them that confidence of safety and efficacy. And, maybe even along the way, not only gaining better control of this sight-threatening disease, but maybe even reducing the medication burden. So, kind of an upside to that story as well.
Yep. And as we finish, I want to encourage the optometrist to think about and find and develop that relationship with your ophthalmologist. Surgical intervention may be a great option in a lot of your patients. I want to encourage the ophthalmologist to also develop that relationship. And I've had many optometrists say, I can start them on a drop, concern for sending a patient out and losing a patient or not having the procedure done. Develop that relationship together, and it's going to be mutually beneficial for our patients for earlier interventional glaucoma, earlier surgical intervention. So with that, I want to thank everybody for their time. Dr. Odell, always a pleasure sharing the virtual stage or any stage with you. Thanks everybody for your attention. Thanks to Sight Sciences for this session. I can encourage you to go to the virtual booth and chat with them at this meeting. Thanks everybody. Have a great day.